So this is Andrew Francis. I'm on the faculty at Penn State Medical School in Hershey, Pennsylvania. And it's my pleasure to be the lead speaker today for today's presentation on catatonia. And I'll be focusing today on the historical development of the Bush-Francis Catatonia Rating Scale, and also a little bit about what is known about its reliability in research settings. I have no disclosures. And there is a website, catatonia.org, which is sponsored by Penn State Medical School. And that has a lot of information, including some instructional videos about catatonia. So as you probably know, the Bush-Francis Catatonia Rating Scale, which was published in 1996, it's the 25th year anniversary of the publication of this paper, has been increasingly used in clinical practice and also in scholarly publications. And this shows cumulative citations, according to Google Scholar, in the clinical research literature. And it's approaching, probably by now, 1,000 citations. So it's quite commonly used and also dominant in research publications. So we published this 25 years ago as a 2-paper set. And I'll talk a little bit about the development of this rating scale and the ideas and concepts behind it. So it was a 2-paper set published in the Acta Psychiatrica Scandinavica. The first paper in this 2-paper set was the rating scale and how we developed it and what its psychometric properties were. And I'll say a little bit about that today. The second paper was the first quantitative treatment outcomes for catatonia using a well-characterized rating scale. This project actually started with a resident, Dr. Bush, who was a second-year resident at my former institution, SUNY Stony Brook in New York. And we had a catatonic patient who was difficult to treat, and we eventually were able to get a court order for ECT. This patient was unable to consent, and the patient, of course, did well and recovered completely. And Dr. Bush approached me and Max Fink. Max Fink was the senior professor at the time. He's retired now, 98, very active, and publishes and carries on correspondence. Dr. Bush approached me and Dr. Max Fink and said, this is so interesting. We didn't know a lot about this, how to treat it. I want to study this. And I told him that in order to study something, you have to have a way to measure it. And the result was the Bush-Francis Catatonia Rating Scale. So I'll talk a little bit about how we did that. It was primarily his project with the supervision of me and Max at the time. So we started, of course, with a literature review. And that's where we really derived the items on the Bush-Francis scale. It has 23 items, which are shown across the top. And how did we pick these items, these catatonic signs and symptoms that we included in our scale? So what's shown here is really the origins of the items in the catatonia, Bush-Francis Catatonia scale. Most of them came from Kalbaum, who first described catatonia in 1874. Some of them, letter D here on the graph, were described by Kalbaum in his beautiful case histories, but not actually named by him, an example of which is ambitendence, which is a motor hesitancy. Others were from Kraepelin, Michael Taylor, other workers over many years of selected research. These were the most significant papers, we thought, in our literature review. And our concept was to include a catatonic item that had been used by at least 2 prior workers. We thought that 23 was a reasonable number. And that's really the origin of where we got these catatonic signs. The DSM series had really a relatively short list of signs compared to the 23 that we ended up with. So we wanted the rating scale to be useful to make a diagnosis, that is to be able to define a diagnosis and also define severity to measure outcomes and response to treatment. So we wanted the same scale to be used for diagnosis and treatment. And the way we conceptualized that is that we would use the first 14 items as a screening, and our criterion was 2 out of 4 signs present, and I'll explain where we got that number. So the screening items, which are the first 14, they're the left of the red line here on this picture, were the ones most frequently used by prior workers and also the most quote, classic, unquote, signs of catatonia. So that's reflected by more black dots left of the red line. And that was the rationale for the choice of screening items. Out of these 14 screening items, we wanted to have the rating scale to be comprehensive, to look for different subtypes of catatonia, which were understood at the time to be excited and retarded, or hyperactive and hypoactive. And out of these 14 screening items, 6 could be considered hyperactive and 8 could be considered hypoactive. So that's the origin of the items on the rating scale, and also the structure of a screening and a full scale for severity. So the screening would be presence or absence of the first 14, and severity would be rating all 23 items on a 3-point scale. So in order to rate them, we had to operationally define them. And that was, of course, a struggle about to do that. So for example, mutism, and each item was on a 3-point scale, each weighted equally. There was no overweighting of some signs versus other signs. 18 of the 23 items we felt could be graded on a 0 to 3-point scale, example of which would be mutism, 0 meaning they talked normally, and 3 meaning no speech at all. 5 out of the 23 items we didn't feel we could categorize as gradations, but we would categorize them as present or absent. And all of these items scored to 3 points. There weren't more points for certain items. Here is the listing of the catatonia signs that are on the Bush-Francis scale. The first 14 are on the left as the screening. 2 out of those 14 would define a case. And then all 23 items would be rated on a 3-point scale for severity. Most of these catatonic signs are observational, shown in red. That is to say, the examiner does nothing except observe the patient. Some of them are elicited. That is to say, the examiner does something and observes the patient's reaction. So for example, echopraxia and echolalia, the patient mimics the speech or movements of the examiner. And some of them are by a physical exam. So for example, rigidity and waxy flexibility, they're abnormalities of motor tone. The catatonia, the Bush-Francis is freely available on the web. And these operational definitions and scoring of these items is included in the web, and is also part of the project that Dr. Wortzel and Oldham will be talking about today. The DSM-5 has a similar concept, 3 signs out of 12. The listing is somewhat different than our list of 14. The definitions I would quibble with. Some examples are shown here. Items 1 and 5 seem to be overlapping in how they're defined, stupor and negativism. But a case defined by the DSM-5 for a psychiatric patient is going to highly overlap with a case defined by the Bush-Francis scale. There's 90+% agreement, typically. Now, so that's sort of the concept of where we got these signs and how we operationally define them. Now, about the setting the criterion of 2 out of 14 to define a case and using equal weighting of all rating scale items. This was an a priori decision because we wanted to capture mild cases. So as we're thinking about the development and implementation of the rating scale, we wanted to capture the mild cases. So we use a low cutoff of 2 out of the 14 being present. And there's some data supporting these 2 choices. That is to say, 2 out of the 14 for a psychiatric patient, and equal weighting of all catatonic signs. And I'll explain what that data is momentarily. So we had data on the prospective sample that we identified on our adult inpatient psychiatric unit. These are psychiatric patients who've been screened to not have gross neurological or medical disorders. So it's an ambulatory inpatient psychiatric population that we studied, and we prospectively screened 215 patients over a 6-month period, all the admissions to the psychiatric adult unit. And that characterized our prospective sample, where we analyzed the data to learn these facts that I'm going to be showing. So the first observation was the frequency distribution of the signs in this psychiatric population. So of the 215 patients, 192, the vast majority had none of these catatonic signs out of the first 14. 8 patients had 1 sign, which was commonly either excitement or withdrawal. common psychiatric symptoms. Nobody had 2. That was going to be our a priori cutoff. One patient had 3. And you see there's a cluster of patients who have multiple catatonic signs. The average was 6. This reinforced the syndromic concept of catatonia, that it's a cluster of signs and symptoms that can be distinctly detected among other psychiatric patients. And it also helped support, after the fact, our a priori choice of using a cutoff of 2 signs to define the cases. Now, something that's largely forgotten nowadays, but was in the literature at the time, was the concept of primary and secondary or cardinal signs, much as the case of major depression where you must have anhedonia or low mood. Some workers said you must have, for example, A, Barnes, must have at least 3 motor signs and at least 1 of 9 other ones. Rosebush, C, must have 3 cardinal signs, or 2 out of 3 cardinal signs plus at least 2 out of 9 secondary signs. So there was this concept of primary and secondary signs. This didn't make sense to us. And in retrospect, it also highly favored the detection only of the so-called retarded or withdrawn form of catatonia, because most of those primary or catatonic or cardinal signs were motor signs of withdrawal. So what we were able to show, even with a sample of 28, is that several of the patients failed to meet who we found met our criteria for catatonia, that is to say 2 signs plus out of the 2 or more out of the Bush-Francis, but failed these other criteria because they didn't have the right combination of primary and secondary signs. So what's shown here is of the people who failed to meet these other criteria, they still had multiple catatonic signs, and they still scored significantly high on the Bush-Francis total score. So that's shown in the last 3 columns. So people who failed these other criteria had 4.8, 4.0, 4.5 on average signs, and of the screening instrument, and 6, 5.9, and 7.8 on the full 23-point scale. So in other words, people who failed these other criteria still were significantly catatonic. So this was a reason that we rejected the idea of counting some symptoms more than others and calling some primary. Related to that was a distinction between the frequency and severity of the catatonic signs in this sample of psychiatric patients. So the top graph here shows in our 28 prospective patients, what was the frequency distribution of the catatonic signs they had. Mutism, immobility, and staring, of course, are quite common in this typical sample of retarded or stuporous form of catatonia. And some of the other catatonic signs like verbigeration, excitement, and echo phenomena were quite rare in frequency distribution among the patients. However, if they were present, they tended to be quite noticeably prominent. So in other words, there was a disjuncture between the severity and the frequency of the catatonic signs. So a catatonic sign that was infrequent might be quite dominant in the clinical picture for any particular patient. And this helped reinforce the idea that catatonia is a heterogeneous syndrome, and that there are going to be subtypes identified. Dr. Wilson will talk a little bit about that perhaps from her research. And the rating scale, we wanted it to be comprehensive to cover all these things, and we didn't see any rational basis to call some signs more significant than others. We also, in the effort to improve inter-rater reliability, which I'll talk about now, developed a standardized approach to examining the patient. And the work of Dr. Wortzel and Oldham has amplified this and did a better job at defining these maneuvers and definitions of the catatonic signs. And it's important to follow this to sustain a good inter-rater reliability in the use of the scale. And this is also published and freely available on the web. So in our original work with the 28 patients, we published the inter-rater reliability by the correlation of scores and also by the kappa test, which is a measure of measured agreement beyond statistical chance of false agreement. And on the left panel is using the first 14 items, screening, presence or absence, 44 ratings across 28 patients before, during, and after treatment. These were prospectively obtained ratings. And you see there's a high correlation between the number of signs detected by rater 1 and rater 2, examining the patient independently in sequence. And also for the full scale severity score, a high correlation of 0.95. The kappas for these two were 0.83 and 0.73, which are considered high kappas. This was prospectively done, and to my knowledge, this is the highest N sample of inter-rater reliability test for the Bush-Francis rating scale in psychiatric patients. Sarkar et al. A few years ago published Catatonia paper addressing the question of using different rating instruments. And they used a different measure of agreement because they had 6 observers independently rating 3 cases. So it's a small sample. And what they found was that the screen and the full scale had a high rate of agreement compared to the Catatonia Rating Scale published by Peter Brenning and colleagues, and also compared to the ICD-10. The DSM-5 was comparable in agreement between the observers. And the paper by Dr. Northoff, who also published a Catatonia Rating Scale using 34 cases. And in this paper, he describes that inter-rater reliability was assessed for several of the rating scales, including the Bush-Francis and the modified Rogers scale, 2 versions of it. But he didn't publish exactly all the detailed data on the agreement. He used the interclass correlation, which is a different measure of agreement for graded steps of a rating, and reports that all 4 of these rating scales, including the Bush-Francis, had extremely high agreement. However, this was a sample of 34 measurements and was mixed prospective and retrospective data collection. So to conclude this part of the presentation, the Bush-Francis Catatonia scale remains the standard for clinical use and research, increasingly so, both domains. It has a rational basis in its design, which I endeavored to explain. It reflects the prior work dating from Kalbaum, from which it's largely derived, who published in 1874. It's broad spectrum and covers a range of catatonic subtypes that have been subject to factor analysis by several researchers. And it has acceptable inter-rater reliability based on the data to date, which derives from clinical research contexts. And the work of Dr. Oldham and Wortzel is an attempt to improve the clinical inter-rater reliability of the Bush-Francis Catatonia scale. So that concludes this part of the presentation, and I'll turn it over now to Josh.
Thank you so much, Dr. Francis. It's my pleasure to speak with you today. Again, my name is Josh Wortzel. I'm a chief resident in psychiatry at the University of Rochester. And today I'll be talking about a study that I was involved with called Prevalent Gaps in Understanding the Features of Catatonia Among Psychiatrists, Psychiatry Trainees, and Medical Students. I have no disclosures. So I have 2 learning objectives for us today. The first is looking at current difficulties with diagnosing catatonia, and the second is looking at how widespread the misdiagnosis of catatonia is and what factors, specifically demographic factors, are associated with that misdiagnosis. So we'll start with the first learning objective, looking at difficulties with diagnosing catatonia. So unfortunately, psychiatrists are pretty bad at diagnosing catatonia, or so has been borne out in the literature. And as you might imagine, it's led to catatonia being pretty widely underdiagnosed. There have been 2 cohort studies that have looked at this on inpatient psychiatry units, and they found in both that only 1 out of every 9 psychiatry inpatients with catatonia was actually diagnosed. 2 prior studies have looked at clinical knowledge of catatonia, which may shed some light on this. The first was a study looking at 20 US psychiatry residents at one institution. They had those participants complete a 3-item survey to identify treatments, signs, and complications of catatonia from a list of 11 correct and 21 incorrect options. And they found that on average, participants only identified 75% of the correct answers, but rated their confidence as a 4 out of 5 on a Likert scale. In the second study, 98 psychiatrists at 11 institutions in Hungary completed a 13-item questionnaire on catatonia. And in that study, half of the participants failed to identify the majority of catatonia features, despite 85% of them rating their knowledge as moderate or significant. And so the overarching idea here is that there's a disconnect between what people actually know and how confident they are in how much they know. So why is catatonia so underrecognized? Well, for one, there may be an underappreciation of catatonia's many phenotypes. Hypokinetic or parakinetic presentations are far more familiar to people, and hyperkinetic presentations can go under-recognized or misattributed. So for example, someone may just be considered to be agitated or have akathisia. There's a polythetic approach to several of the diagnostic scales. So this is true for both the Bush-Francis as well as the DSM. And what does this mean? Well, basically a polythetic approach means that you have a list of possible presentations of catatonia or features, and you need just a certain number of them, let's say 2 or 3, to constitute a diagnosis of catatonia. So for the Bush-Francis, this means that any 2 of the first 14 items equal catatonia, and for the DSM, any 3 of the 12 items. This means that there could be literally hundreds of unique presentations of catatonia based off that diagnostic system. And what makes it even further tricky is that many of the catatonia findings themselves can present in multiple ways. So just as an example, hand waving, head rocking, and foot tapping are just a few examples of stereotypy. Another issue to consider is that there's discrepancies between the different catatonia scales that are out there. So for example, in the DSM, some of the Bush-Francis Catatonia Rating Scale items are excluded. These include Mitgehen and Gegenhalten. And even some of the terms that are used in both scales are defined differently. So for example, waxy flexibility on the DSM is defined as basically increased tone throughout the whole range of movement, whereas on the Bush-Francis, it's increased tone that limbers up as movement is continued. And then there's the fact that there are multiple scales. So I've already mentioned the DSM and the Bush-Francis, but there are others, including the Browning's Catatonia Rating Scale and the International Statistical Classification of Diseases and Related Health Problems. So this just makes having a universal way of looking at catatonia a bit trickier. So let's just briefly recap then the key takeaways from this learning objective. So unfortunately, right now, we're missing the diagnosis of catatonia in many patients. In fact, only 1 in every 9 inpatient psychiatry patients with catatonia is accurately diagnosed. There's a discrepancy between what people think they know, clinicians think they know about catatonia, and what is actually accurately known about catatonia. And this may be due to a couple of things. One, there are literally hundreds of unique presentations of catatonia, making it hard to have a good clinical gestalt of what it may look like. 2, catatonia features can present in a multitude of ways, further complicating the diagnostic picture. And lastly, there are discrepancies among the scales, which make having a clear diagnostic appreciation a little less intuitive. So let's move now on to the second learning objective, which is how widespread the misdiagnosis of catatonia really is, and to think about some of the demographic factors that are associated with that. And that was really the focus of the study that we conducted. So to do this in our study, we developed 2 versions of a test to assess people's knowledge of catatonia, Forms A and Form B. And these 2 tests had corresponding questions assessing the same concepts with approximately the same level of difficulty. I'll just say that the reason why we had 2 test forms is because this was actually part of a larger study where we did pre and post testing. But for the purposes of this presentation, we'll just be looking at pre-test data. The test was comprised of 2 different sections, the first being a 50-question multiple choice test. The prompts were providing a description of a clinical finding. The participants were asked to select which catatonia finding was being described from a list, and the maximum score for that portion of the test was 50 points. The second portion was a standardized patient exam, and this consisted of a 3-minute standardized patient video that participants scored using a Bush-Francis Catatonia Rating Scale. And of note, we had scored their answers dichotomously. So on the Bush-Francis, you can rate the severity of a finding, but we were just curious to know whether a participant could identify whether a finding was present or absent. And so the maximum score was a 23 for that portion. We recruited medical students, psychiatry residents and fellows, and psychiatrists as part of the study. To do this, for medical students, we had recruited clerkship students on their psychiatry rotations at the University of Rochester, as well as had emailed the listserv for the Association of Directors of Medical Student Education in Psychiatry. For psychiatry residents and fellows, we emailed the American Association of Directors of Psychiatry Residency Training, or ADPERT, which they then distributed, those program directors distributed to their trainees. And then to recruit psychiatrists, we had emailed the membership of the Academy of Consultation-Liaison Psychiatry. Some of you may have taken it. And the participants were able to enroll in the study and take the tests between October 1st and December 31st of 2020. So I just want to go through a couple examples of what these questions looked like. So here were the first 3 from Form A. Basically, for a cluster of questions, we kind of gave a grouping of the features. So in this case, bizarre behaviors. The first question said a patient being examined in the hallway suddenly starts removing their clothes for no reason. So this would be an example of impulsivity. When asked to tap on a desk 3 times, the participant taps 10 times. Well, this is actually an example of motor perseveration, and so they would have selected other. And finally, when asked to keep their arms outstretched and resist upward movement, the patient's arms easily rise with slight upward pressure from the examiner. And that's the definition of mitgehen. I also just want to show a brief video of, or a brief snippet of the video that they used for the standardized patient portion, just to give you a sense.
Hi, Mr. McGuire. My name is Dr. Oldham. Hello. What are you doing there? I'm drinking. Go and take a sip. No. All right.
So you can see a couple of things already. One, I'm exhibiting ambitendency, and I was not actually catatonic for that video. I was just acting, but I was exhibiting ambitendency, negativism by saying no, and I'm posturing during the video. And there are a couple other findings that are present as the participants watched. So here's a diagram of which participants were included. You see here for Form A and Form B. Participants were pseudo-randomized, so they were able to choose which one they took based on their birthday. So for Form A, even birthdays like November 4th would have gone to Form A, and Form B would have been odd birthdays. Overall, the survey was opened 839 times. 512 people completed the survey, and ultimately 482 participants completed the survey and met inclusion criteria, which again, medical students, psychiatry residents and fellows, and psychiatrists. Here's a demographics table looking at the total scores by test form, so A and B, as well as aggregated. The demographics for each test were pretty similar. You can see here the p-values. We used a cutoff of 0.005, just given multiple comparisons. And just to look at the aggregate data, roughly there were equal proportions of people who identified as men and women. A third of participants were under the age of 30, around a third were between 31 to 35 years old, and a third greater than 35 years old. Around 90% of our participants were from the US, and our participants represented 36 US states and territories, 10 countries, and over 150 medical institutions. Most of our participants were residents and psychiatrists. Just looking at the 2 largest groups, Around 45% were psychiatry residents and 40% psychiatrists. The scores on both forms of the test were relatively equivalent. You can see that there was no statistical difference for either, although there was a trend towards difference for the standardized patient portion. This difference, however, was quite small, of less than a point. Overall, when we look at the aggregate score, unfortunately, the performance was pretty poor. We see that only around 55% of the multiple choice questions were answered correctly, and around 69% of the standardized patient questions. Here are the aggregate scores, so combining test form A and B stratified by demographic. Just a few things to highlight here. On the multiple choice portion, we see that psychiatrists did perform slightly better than residents by a couple of points, and residents did perform slightly better than medical students as well. However, we don't see this for the standardized patient portion. There was no statistically significant difference. And we really don't see any other differences by stratification for region or age. However, you can imagine that there could be some level of confounding or the influence of different factors. So we created linear regression models where we had the test score as the dependent variable and the various demographic factors as the independent variables. And we did a model for score on the multiple choice portion as well as on the standardized patient portion. We found that regarding training level, there was an association. Compared to medical students, psychiatrists scored around 7 points higher on the multiple choice test and around 2 points higher on the standardized patient portion. Interestingly, residents and fellows did not have a statistically significant higher score than medical students on the test, though there was a slight trend for higher performance. There was a significant inverse association between age and score on the test. So specifically compared to participants who were less than 30 years old, participants who were greater than 45 scored around 4 points lower on the multiple choice test and around 3-ish points lower on the standardized patient portion. And there were no clearly consistent differences by gender, self-identified gender or region, although I will give a quick shout out to the people in the Midwest who performed around a point higher on the standardized patient portion. So let's just briefly summarize then the takeaways from our second learning objective. So when it comes to looking at how widespread the misdiagnosis of catatonia is, as well as demographic factors associated with it, we see that on average, participants in our study, which represented a large swath of American psychiatry at all different stages of training, as well as even international representation, they answered only half to 2/3 of our questions correctly. Psychiatrists performed only slightly better than medical students. Older participants performed worse than younger participants on average, and region and gender were not meaningfully associated with test performance. So what then are the takeaways from my presentation? Well, for one, unfortunately in psychiatry, it seems there still is quite a low accuracy in identifying individual catatonia features using the Bush-Francis. This can have variable effects on the diagnosis of catatonia, likely leading to false positives, so identifying people as catatonic who are not actually, as well as false negatives, missing people who are catatonic. And we know that this is happening as we previously discussed in those studies. As you can imagine, this affects clinical care, but also research. If we don't know that we're all talking about the same thing when we report on stereotypy, that really is a hindrance to our ability to push the field forward. And this suggests that there really is a need for education to clarify what each of these catatonia features really is, including continuing education, as we see older participants were even more likely to answer things incorrectly. And in fact, this is something that our group has created in terms of educational material, but we won't be commenting on that today. Just want to briefly acknowledge some key people, some of them who you will meet today and have met. Dr. Mark Oldham has been my supervisor for the past 2.5 years and has been just such a tremendous support to my professional and personal development and mentor on this project. He'll be speaking to you next. Dr. Francis, who you've already met, is such a leader in the field and was such a pleasure to work with, an honor to work with as a colleague in this paper. Dr. Mang was a statistician and also helped with the study. Dr. Lee is the chair of psychiatry at the University of Rochester and funded the project and has been there for both academic and moral support. And finally, the University of Rochester and our skills lab, where we recorded the material for free. We really appreciated their support. So thank you so much. It's now my pleasure to hand the presentation over to Dr. Oldham. Thank you.
Hello there. Thank you so much, Josh. It really has been a pleasure to work on this project with you and also with Dr. Francis. And so the title of the overall workshop is Think You Know How to Spot Catatonia. Let's talk about that. And I'm going to continue the trend of what you've just heard, a little bit more of the results from the same study, but we're going to drill into the specific items on the Bush-Francis and look at the specific items that were missed most commonly on this test. So first off, I have no disclosures here to report. And so what I really first off want to highlight is the training manual and coding guide, which is available online. This is the table of contents. You can access the guide and our materials here at this very small, I guess they're called vanity URL. So BFCRS for Bush-Francis Catatonia Rating Scale, urmc.edu, and all the resources are there. This is the table of contents. What I'm going to be focusing on, though, again, are those items that were missed most commonly. And we have dedicated an entire page in this guide to each item on the Bush-Francis. And on that page, we describe the item. We kind of give a description of kind of how to think about it, how you identify it clinically. We differentiate it from closely related items. And then we provide a few illustrative examples of how that item might present. So I would encourage everybody to take a look and join the conversation. If you have questions about it, if you'd like to greater clarification, again, we want this to be a conversation and really so that people understand and have a sense of exactly what these items represent. And really that gets to this image here on the right, which is there's a difference between accuracy and precision. Both are very important. So you've already heard Dr. Francis talk about the reliability of the Bush-Francis in research settings when everybody has kind of the same definition. But really, clinically speaking, I think it's very likely, based on the results of this study that we did, people are using different definitions for these items. And so we want this not to be only reliable or a measure of precision, we also want it to be accurate. So these are the items specifically on the Bush-Francis. On the left is the screening instrument, on the right is the full-scale items. And I've color-coded them. I'm not going to go through each of the color-coded items and the percent right on each. You can pause the video or review this in our published manuscript. But essentially, I want to highlight those that were scored correctly less than half of the time, either on the multiple choice or in scoring the standardized patient. And I'm going to use images to hopefully create a little bit more of an intuition about each of these items. So a lot of pictures, all of them are Creative Commons licenses. So I don't believe I'm breaking any rules for sharing them and using them in this format. So for starters, immobility stupor, slow to no motion. What you see here is a riverbed with a bunch of pebbles or rocks, and you have ice. When you think about immobility stupor, think about being frozen, kind of frozen in time. And so essentially, this is extreme hypoactivity, immobile or minimally responsive to stimuli. Really, one of the key features here that I think might be tripping people up is this is not against gravity. It is out of proportion to context. It's generalized, so it's not just posturing in one limb or two limbs. It's really a generalized assessment, but it has nothing to do with gravity. This is simply the overall degree of movement. And it says nothing of muscle tone. Some people can be immobile with increased muscle tone or rigidity. Others can have no rigidity and still be immobile or have this item. Number two, posturing and catalepsy. This is a delightful picture. I'm going to presume that the child made it back down to the bed safely, but essentially you have a child and the doll, and they are in the air against gravity. Think anti-gravity when you think posturing and catalepsy. That is the unifying theme. So specifically, posturing is an actively assumed position. The patient places themselves in that position, whereas catalepsy is passively assumed. The examiner moves the patient's arm or another part of their body, their leg, to a position, and then they maintain that posture. And again, in both instances, this is done against gravity. And it's against gravity for no apparent reason. It commonly co-occurs with increased tone on physical exam, but it doesn't have to. So these are different features. And I will note that posturing and catalepsy in the DSM-5 are separated. So they are scored as separate items in the DSM. In the Bush-Francis, they are scored jointly. Echopraxia, echolalia, and you'll see what I did there. I've echoed it. But when you think about this set of criteria, I should say this item, these represent echo phenomena. Think about a mirror. A mirror is not actively doing anything. It's simply reflecting what is being cast upon it. And in the same way, echopraxia and echolalia essentially mirrors something that's happening in the environment. So echopraxia is the mimicking of an examiner's movements, echolalia, mimicking of speech. So again, like a mirror, it just is spontaneous, it's automatic, and again, just happens really without a great deal of obvious thought or intent. It serves no clear purpose. And like we just saw with the prior elements, these are also scored separately in the DSM-5. Again, they're scored jointly in the Bush-Francis. Next, stereotypy versus mannerism. Now, this is the odd one out. These can be really kind of difficult, I think, at times. I'll just say personally, they can be difficult to really differentiate and identify. But I'm going to hopefully provide a way to think about this. This is something Dr. Francis had taught me and Dr. Wortzel about, kind of the way that he conceptualizes this. They're both odd, but they're odd for a different reason. So with stereotypy, this is a repetitive, non-goal-directed motor activity. It's odd in its repetition. So it's not odd that a person would stroke their chin or scratch their head for, I don't know, 10 seconds. It is odd if they continue doing that for 15 minutes. So again, it's not odd because it's done, it's odd in its repetition. Mannerisms are odd inherently. So there is a purposeful component to the action, like moving, let's say ambulating, but instead of walking, they're hopping. Or instead of speaking fluently normally with an appropriate cadence, maybe they have a sing-songy or robotic inflection in the way that they're speaking. So it's inherently odd. There's some characteristic of the behavior that is inherently odd. Now, both of them are spontaneous. One notable distinction between them is stereotypies are only behaviors. They don't include speech, whereas mannerisms can occur in behavior or speech. So you can have a manneristic behavior or manneristic speech. And in both, you would exclude facial expressions. So facial stereotypies or mannerisms would, according to the Bush-Francis, be scored as types of grimacing. Next is rigidity and waxy flexibility. It's all in the tone. And you cannot see rigidity or waxy flexibility. You feel rigidity or waxy flexibility based on a physical exam of the patient's extremities. Typically, it could be the neck as well, or perhaps other parts of the body, but typically the arms would be a classic place to elicit this. So again, both of them are identified based on exam. Now, rigidity is increased tone throughout the arc of movement. So not just as a part of the movement, this is really throughout the entire arc of passive range of motion that you're examining. Whereas waxy flexibility, according to the Bush-Francis, is initially increased tone that lessens or melts as you limber up that limb, that arm. So again, they can co-occur with one another, and they often do, but they are distinguished based on when and how long specifically they present. It's notable also that the DSM-5, and you heard Dr. Wortzel say this, the DSM-5 defines waxy flexibility differently. It defines it as firm, even resistance, I believe, actually, I have it right here. I should look it up. So it defines it as slight, even resistance to positioning by the examiner, whereas rigidity is not in DSM-5. So essentially, you would be scoring these a bit differently in the DSM-5. Next is negativism, which is oppositional or opposite. As you see these two, and I should have looked up what kind of animal this was. Someone's probably screaming at their screen right now saying exactly what it is. But essentially, negativism is being oppositional or doing something quite the opposite of what's being asked. And in my experience, I would say this might be one of the hardest ones to get my mind around. Because there are a few notes here. Failing to stop another catatonic feature is not negativism. So if a person is not speaking and you say, repeat this after me, that's not negativism, that's mutism. Or if they're posturing and you say, I want you to lower your arm, go ahead and lower your arm, and they don't, that's still posturing, it's not negativism. So really you have to identify some feature, some element of their presentation, some movement, some absence of response to instruction, where there is reason to believe, if not demonstrable evidence, that they can do the activity. So a few kind of classic examples would be if the person has their eyes closed and yet you say, all right, I'm going to try to open your eyes, and they clearly try to oppose you and they squint their eyes when you're trying to open them. That would be an illustration of, or an example of negativism. Also, for instance, if you can see and you see that they've moved their neck just fine throughout the interview, but then you try to examine their neck and say, all right, I want you to loosen your neck. I'm going to move it to the left and to the right, and then they clearly oppose you. That would also be an example of negativism. And then if you're engaging with somebody and having a conversation and everything that you ask them is constantly a no, and they're just not giving answers, and they're saying no in very almost kind of an automatic fashion, and contrary to everything you say, that might be another example of negativism. But I think that you'd really have to kind of consider the context of the behavior before scoring it as such. Withdrawal is essentially, I think it's fairly, it's concrete in terms of how we define it in the Bush-Francis. This is simply the refusal to eat, drink, or make eye contact. And you might think about that kind of in line with severe depression. So you can elicit it to some extent by putting food in front of a person, preparing their meal, putting a straw in the cup, and they're just not eating. I mean, that would be pretty clear, demonstrable evidence of withdrawal. And in terms of eye contact, these are very often in this context, a person averts kind of their gaze away from people. And so you try to get into their field of view, and then they kind of keep looking away, and kind of their gaze kind of darts away from the examiner. Would be another way of demonstrating withdrawal. Next is ambitendency, or getting stuck. So just like this truck here is, I'm going to presume, fairly stuck in the mud. Same idea here with ambitendency. And there are two general ways that this might look. So on the one hand, they can be stuck during the action. And so a classic way to elicit this would say, don't shake my hand, and then you extend your hand to shake theirs, and they might reach out and get stuck, kind of indecisive, not knowing if they should shake or not to shake, and then they just pause, and they're kind of in suspended animation. That would be an example of ambitendency. Another one would be, as you saw in the brief video that Dr. Wortzel showed, which is someone can be vacillating in ambivalence. So, just trying to eat and not eat, and it's just kind of wavering there, or trying to enter a room and not enter a room, kind of stuck in that way, or trying to get up from a chair but not trying to get up. Again, another form of vacillation, which would be scored as ambitendency. Next, perseveration, more of the same. So here you have kind of the balustrade with each of the I believe they're called balusters. So they're just stones that are carved and they look the same. So perseveration is more of the same. And so this can look in one of two ways. It can be verbal or motoric. So with verbal perseveration, the person comes back to the same topic or gives the same response to multiple questions in succession. This is to be differentiated from verbigeration, which is scratched record. So is it 10 o'clock? Is it 10 o'clock? Is it 10 o'clock? That would be verbigeration. It's the same, that same kind of bit of information being given again and again and again. But again, that would be verbigeration as opposed to perseveration here. And then motoric perseveration is when a person is doing something that was induced, so like shaking a hand, but the activity continues and slowly abates even after the handshake is done. So again, it's almost like there's a momentum in the perseverative action. And finally here, the last one that I'll cover is combativeness versus impulsivity. And I'm sure my son would love this because he loves Lego. So essentially, the way to differentiate combativeness from impulsivity is the object in the context of combativeness, the object of that activity. So is there danger? Is there striking out against another person? So combativeness is by definition toward a person striking out and there is some possibility of danger. It's sudden, there's a lack of clear rationale, but there is typically a risk of injury. Whereas on the other side, impulsivity is also sudden, lack of clear rationale, but it specifically excludes actions directed at a person. So again, combativeness might present impulsively, but that would be a carve out from, if it does present impulsively, as it typically does, it would be a carve out from scoring impulsivity. And impulsivity also notably is inappropriate to context. So with that, I'm going to go ahead and wrap up. Next, I'd like to welcome Dr. Wilson, who will be talking a bit about catatonia and delirium, kind of a very difficult but really important consideration here, specifically in the critically ill and how we might differentiate these clinically. Thank you so much for your time.
Hi, my name is Joellen Wilson. I'm an assistant professor in psychiatry and behavioral sciences at Vanderbilt University Medical Center, and I'm excited today to be talking to you about catatonia assessment in the medically ill. I have no disclosures to report. So many of us, if not all of us, appreciate the clinical relevance of catatonia for our patients. Catatonia, if left untreated and unrecognized, can lead to a whole host of morbidity and mortality for our patients, including events such as aspiration, dehydration, malnutrition, contractures, pulmonary emboli, rhabdo, and renal failure. Catatonia in the medically ill has been described over recent years. Catatonia is now recognized to be a common manifestation of medical illness, and the incidence of catatonia ranges from anywhere around 2% to 9% on a psychiatry liaison service, although I do think better estimates are needed. And it obviously varies across age group and associated medical conditions. Catatonia has been frequently recognized as a medical condition in recent literature. Taylor and Fink have advocated that catatonia should be given a home of its own in diagnostic systems. And we've begun to recognize catatonia as a type of spectrum illness, that being that catatonia frequently presents itself in the setting of a variety of different illnesses, such as delirious mania, serotonin syndrome, neuroleptic malignant syndrome, and autoantibody-mediated encephalitis. So for most of us who practice in the medical setting, as a psychiatrist, this is oftentimes what we're asked to think about when we are asked to evaluate a patient with altered mental status, acute brain dysfunction, where catatonia might be on the differential. You have a medically ill patient who has some type of brain dysfunction, and you're asked essentially to be Sherlock Holmes and make a diagnosis. And I just want to point out here that the diagnosis that's made is oftentimes made through the lens of our prior experiences. So for example, if an intensivist was to evaluate the same patient, they might call the patient delirious and fail to recognize catatonia. If a gastroenterologist was to evaluate the same patient, They might look at the patient and say, ah, they have encephalopathy. But, we're tasked with oftentimes thinking outside of diagnostic constructs and wearing several different hats, employing our physical evaluation skills as well as our critical thinking skills and evaluating cognition. And so we may evaluate the same patient and say they have both delirium and catatonia. So that's what we're going to talk more about in this session. So this was a simplified schematic that I came up with along with Shaniqua Williams-Roberson, who is a neurologist and epileptologist here at Vanderbilt. We were trying to educate intensivists to think about how catatonia may co-occur with delirium and coma and how you might be able to start to differentiate one from the other. I'd say that intensivists are very commonly evaluating for coma and now more so than ever delirium, but are very unfamiliar with catatonia as a diagnostic construct in this patient population. And so you can see how we have started to ask them to appreciate some of the unique differences between each of them. And because I think coma is less well recognized in our group here, I'll talk just briefly about coma. So coma is unique from delirium in that coma is disordered arousal. It's typically evidenced by a lack of responsiveness to stimuli. And there are no defensive movements to nociception that the patient is able to employ. So I really like this paper. This was a paper that was published now almost 10 years ago. That was a retrospective chart review of 54 cases of catatonia over 3 years at an academic institution. And they identified that catatonia was prevalent in this population, and that the clinical suspicion of comorbid delirium was the strongest predictor of a more thorough general medical workup. This should come as no surprise to us, although it speaks to the uphill battle that we have to climb. An attribution of catatonia to a psychiatric etiology was associated with significantly less diagnostic workup. Grover from India published a really interesting prospective cohort study of patients with delirium. He used the DRS-R98 and used the Bush-Francis Catatonia Rating Scale to evaluate for catatonia in this cohort. 39% of the patients in the study had 2 or more Bush-Francis Catatonia Rating Scale items present, and 32% met the Bush-Francis Catatonia Screening Instrument criteria. 12% met DSM-5 criteria for catatonia, and they found that the co-occurrence of delirium and catatonia was more common in women, in those who had delirium onset prior to hospitalization, and in those with hypoactive delirium. Dan Sadi-Konefka, who is an intensivist out of Harvard, published a really interesting study that asked us to think about catatonia in the ICU. This was published in Critical Care Medicine, and this was one of the first papers in the critical care literature that highlighted the need to recognize catatonia in this patient population. So I was really excited to see this when it got published. And he basically said that catatonia is an important and under-recognized cause of altered mental status in the ICU. He did a retrospective case series of patients with catatonia in the ICU. These patients ranged in age from 17 to 78 years. And he highlighted the fact that current screening tools for catatonia were nonspecific in the ICU setting and proposed a diagnostic algorithm. This is what he proposed. I do not advocate the use of this, this tool to assess for catatonia, but I do think that in a non-psychiatrist-led setting where you're asking people to think about catatonia on the differential, this is a very helpful tool and rubric because it asks them to, one, think outside the box, think about whether or not some neurobehavioral or biologic change may be more than simple delirium or coma, and to ask them to do a more thorough examination, not only physical examination, but perhaps medical examination, including EEG, MRI, lumbar puncture, additional chemistry test as well. And to consider use of a lorazepam test or other treatment or management strategies for catatonia in those who have altered mental status that cannot be explained only by delirium or coma. So I like this for that purpose. but we should not be making a diagnosis of catatonia based off of this simplified algorithm. So this led us at Vanderbilt to pursue our own cohort study of delirium and catatonia in critically ill patients that we called the DCAT study. And because I've previously presented this here at ACLP in previous years, I'm not going to go into the nuances of this study, but I want to just highlight that we have an ongoing prospective cohort investigation of critically ill patients that we are evaluating for delirium and catatonia. And this is done here at Vanderbilt. This is just a brief snapshot of our beautiful campus. And some of the results from the initial description of this cohort from 136 patients showed that this was a critically ill sample. The SOFA score equates to severity of illness, and the Charlson score is essentially a comorbidity scale. And these were patients who were critically ill for a number of different reasons: sepsis, septic shock, acute respiratory distress syndrome, pneumonia, or other airway disease. So you can see just how critically ill these folks were. These folks were at late middle age. And the distribution of acute brain dysfunction in this cohort, about 3/4 of the cohort experienced delirium during some sort or during a portion of their stay. Around 40% of those ended up experiencing catatonia according to the DSM-5. Of those who did experience catatonia, about 91% of those were also delirious at the same point in time. And about 1/4 of the patient sample experienced neither delirium nor catatonia during study participation. The prevalence of catatonia signs were recognized here, and these are all the Bush-Francis Catatonia Rating Scale items listed. I would say that even though we used the DSM-5 criteria, 3 or more of 12 items being present as our reference evaluation, we did evaluate all patients using the Bush-Francis Catatonia Rating Scale because we liked the fact that it screened for many more items from a descriptive purpose. And then we matched it via an algorithm to the DSM-5 scale. And you can see that across the board for delirious in the black bar versus non-delirious patients in the gray bar, all catatonia items were much more prevalent in the delirious group than in the non-delirious group. And I've shown that same figure here on the left side of the screen on the left side of the screen. On the right side of the screen is a very similar image that is from a schizophrenia research paper that I wrote with Stefan Heckers and Kathy New. And this was in a mixed medical and psychiatric population. This was a retrospective cohort of over 300 patients with catatonia. Most of these patients were patients with severe and persistent mental illnesses and were hospitalized at our psychiatric hospital. And we described the prevalence of different Bush-Francis Catatonia Rating Scale items that were present within the cohort. And you can see that the similarity of the items present actually is fairly similar in a severe psychiatrically ill population versus a critically ill population. And from our critical ill cohort, we showed that with increasing number of DSM-5 catatonia items present, it increased the probability of developing delirium. And essentially for a reference point, this odds ratio that was generated was the comparison point between 3 DSM-5 items present, so essentially having catatonia, versus the 25th percentile of items present, which was 0 items. So if you had catatonia according to DSM-5, you had nearly 28 times the odds of being delirious at the same point in time. And delirium in this study was evaluated using the confusion assessment method for the ICU. We developed revised cutoff points on the Bush-Francis Catatonia Rating Scale in order to be able to have more certainty around the catatonia diagnosis in a population where delirium and coma were quite high comorbid. So we suggested that the use of 4 more items was associated with a fairly equal sensitivity and specificity around 90% for each, and that if you were going to potentially modify treatment, including the use of a lorazepam test, which may be somewhat controversial in a critically ill population, then you might want to use 5 or more items. So the question is, can catatonia be assessed in the context of coma? I think that's one burning question that I frequently get asked. And the answer is yes. So how do we assess for coma at Vanderbilt? Well, for our research studies, we use the Richmond Agitation and Sedation Scale, or the RASS. And I put some of the references here that you can just quickly look at. But for the point of this discussion, the RASS is a 10-point scale, ranges from -5 to +4. 0 is alert and calm, with increasing numbers up the scale. So from 1 to +4, you get increasing levels of anxiety, restlessness, and agitation, to the point where +4 would be someone who's very combative, violent, and immediate danger to self or others. With decreasing levels of arousal and increasing levels of sedation, you can approximate coma. So -4, no response to voice, but movement or eye opening to physical stimulation. And that's typically fairly painful physical stimulation. So navel pressure, sternal rub, or a -5, no response to voice or physical stimulation would equate to coma. So here at Vanderbilt, for the definition of coma in our research studies, we use a RASS of -4 or -5. So when I think about, and these are just some general kind of thinking points here, when I'm going to examine a patient who might potentially be comatose, I consider a few different things. One, I always try to get collateral from family, nursing, and care staff. I want to understand how the patient's been behaving and acting over the previous 24 hours. How is this different from their baseline? How is this different than the day before? I also want to review the medical record closely to understand what types of procedures the patient's had, what medications they've received, and understand the overall clinical picture of what's going on with the patient and what may help explain why the patient is looking as they are at the time of my exam. So aside from getting really good collateral, talking to friends and family, talking to nursing staff, and reviewing the patient's medications, I'm gonna have a keen eye to assess for whether the patient has been receiving sedation, either continuous sedation or bolus medications such as Precedex, et cetera, that may explain why the patient is immobile or failing to respond to me. I'm also going to look to see if the patient has received any type of paralytic medication in the previous 24 hours, which might also explain why the patient is immobile. I'm going to look for devices that the patient might be attached to. So is the patient mechanically ventilated? Are they attached to a dialysis machine? Have they been recently restrained for a number of reasons? And I'm going to assess the overall medical condition of the patient. So we've talked about that briefly already. And, you know, when I assess someone with coma, or I'm concerned might be heading into coma, I'm very careful not to overcall individual signs. And so I'll talk about that in just a moment. And I think Dr. Oldham talked about that as well. At Vanderbilt, we have created somewhat of a modified Bush-Francis Catatonia Rating Scale form for research purposes. And for every one of the 23 items, we've added on another option. So either a fourth option or a third option, where we say that that particular sign is unable to assess. And we assess that on a sign by sign basis, depending on the unique clinical situation going on with the patient. So for example, if a patient is on mechanical ventilation and they are sedated, I am unable to assess mutism, right? If a patient has received paralytics recently and they are sedated, I am unable to assess immobility for the most part, okay? But there are many signs that I can assess. And so this is a modified picture of what Dr. Francis showed earlier when he talked about the importance of observation, interview, and physical examination of the patient who you're evaluating for catatonia. This was a checklist that was put together by Dr. Heckers, and it includes all 23 Bush-Francis Catatonia Rating Scale items. And in red, we've highlighted the DSM-5 catatonia items present. And you can see that these are made up of abnormal psychomotor behaviors, decreased psychomotor behaviors, and increased psychomotor behaviors. And I would advocate that many of these you can actually examine in a delirious patient, and several of these you can examine in a comatose patient. And so here's just a quick checklist of some of the items that I think about examining in a patient with coma. Not all of these will be able to be evaluated in every patient, but on a case-by-case basis, I think about these unique DSM-5 items, immobility and stupor, particularly if the patient has not received recent bolus or continuous sedation. So patients can be comatose for non-sedative reasons. And so we're oftentimes asked to sort that out. And catatonia could be a reason for that. So I always assess for immobility and stupor, but I make careful notation of whether or not it may be related to medication. I also assess for grimacing, posturing, negativism, and I really like Dr. Oldham's example of the eyelid opening. That is one of the things that I oftentimes do to assess for negativism in comatose individuals. I assess for mutism if it's relevant, but in many of these patients, they're going to be mechanically ventilated, they're going to be sedated, so I'm not able to assess for mutism, but there are some on a case-by-case basis where I can. Waxy flexibility, catalepsy as well. Additionally, Bush-Francis Catatonia Rating Scale items that are not represented fully in the DSM-5 that I can assess for in many patients: grasp reflex, staring if appropriate, rigidity, Gegenhalten, and of course, autonomic abnormality, although in many cases that may be related to their underlying critical illness. So here at Vanderbilt, we have continued to grow that cohort, and we've assessed for coma now in an updated cohort of over 378 critically ill patients in DCAT. We've added on a trauma cohort. So you can see that nearly a quarter of our patients come from the trauma ICU. And the rest of the demographics here support that this is a non-cognitively impaired population at baseline that are now critically ill. And you can see the indications for ICU admission. What we have shown here in this paper that's currently under review is that catatonia, the co-occurrence of catatonia and delirium, and the co-occurrence of catatonia and coma increase across quartiles of age. So we divided up the quartile into unique quartiles of age: 18 to 46, 46 to 58, 58 to 66, and greater than 66 years. And you can see that as you move across quartiles of age for any of these three unique groups that I talked about, the prevalence of the disorder increases across age, which may suggest that catatonia may be associated with aging. And we did a heat map here to understand the correlation of unique Bush-Francis Catatonia Rating Scale instrument items that might be present and co-occurring in this critically ill cohort. And it's often of a hypoactive variety. So mutism and immobility, staring and mutism, staring and immobility co-occurred the most frequently in this unique cohort. Just briefly about future directions, I think we need to understand how pre-existing psychiatric illness relates to catatonia occurrence and incidence in the medical setting as we start to sort out all these other variables that may be contributing to the catatonia phenotype in our patient population that we frequently take care of. Additionally, this was a figure I helped generate for a recent Nature review that we wrote on delirium. And I think as in the delirium literature, we've got pretty good at understanding some of the unique pathophysiologic and biologic mechanisms that may be contributing to the delirium phenotype. We need to start to understand, especially with the high comorbidity of delirium and catatonia and coma, how some of these pathologic mechanisms may be contributing to catatonia itself. And so I'll finish here with our funding and our research group. I'm a member of the Critical Illness, Brain Dysfunction, and Survivorship Center. And I want to thank my mentor, Dr. Wes Ely, as well as many other members of our team that have supported this research, as well as the VA, which helps fund some of my time. Thank you for your attention.
All right, well, welcome to the last slide. We're putting this in at the end because we thought that it would be a good opportunity to highlight a few, just a few considerations when it comes to scoring the Bush-Francis Catatonia Rating Scale. And so there is a whole page in the training manual and coding guide that that outlines each of these, but we want to highlight them here just so that you guys have some kind of guidance on these elements. The first is indicating timing. Now, there's no formal way to assess or define the amount of time that a Bush-Francis Catatonia Rating Scale is being assessed. So we have proposed, and this is something to consider going forward and also in research, to define interval assessments that would take a specific period of time. And so it could be an 8-hour assessment or a 24-hour assessment, and you include all criteria present over that 24 hours. And that might include collateral informants and the like, versus a state assessment. And it's really important after a lorazepam challenge to think about this in terms of a state assessment, because it'd be very difficult. The person had a finding an hour before, but you're counting it prior to lorazepam, and now they're not demonstrating it, but it's something that's been showing up intermittently. You really want to be able to have clean assessment, kind of a reference point when scoring. So when scoring the Bush-Francis, we would suggest that it be defined either as an interval or a state assessment. Number two, it is recommended to exclude known pre-existing neurological symptoms. There is one note about this. Autonomic abnormalities, though, in a medical illness do count toward autonomic abnormalities when scoring the Bush-Francis. Number three, you've already heard Dr. Wilson talk about this, and this recommendation comes directly from the DCAT study. So in a patient who has delirium, we would recommend that at least 4 Bush-Francis Catatonia Rating Scale items be present before defining a patient as having catatonia in terms of caseness. And the final one also, in many ways, I think this is echoing something Dr. Wilson said, and that is excluding equivocal features. It can be very easy to just kind of score people in, and if you're on the border, you know, we'll just kind of score them in. I think it would be much cleaner to score only those features that are unambiguous. And specifically, when it's unclear whether a particular finding might represent one item or another, to score it as one item only, not to double score on any given item. So we hope these are helpful, and we refer people to the scoring guide to learn more about each of these keys. Thank you.
So we'll have some questions and answers, and I'll start off. Dr. Wortzel, you presented some information about seemingly poor recognition of catatonic signs and symptoms. What would the context be for a similar sort of assessment of things like delirium or depression or mania among psychiatrists and residents? Is this way out of line for what you might expect for clinical agreement?
Wonderful question. And I have to say, I don't know what the state of, the accuracy of diagnosing those other disorders is. And it's not so much necessarily a criticism of catatonia as opposed to our ability to diagnose other things, but rather just highlighting the fact that this is an area that the field needs to improve upon.
So I'm a lot older than you, and my recollection is that the DSM system was designed to improve integrated reliability of diagnosis, and I think it has. And so it's interesting that so far, at least, the catatonia diagnostic systems don't seem to achieve that same goal. My question for Dr. Oldham is guideline.
Absolutely. So first off, we have a website at the University of Rochester. We have a website at the University of Rochester Medical Center, and we try to simplify the URL. So BFCRS, I know I'm just saying out the letters. This is weird, right? BFCRS for Bush-Francis Catatonia Rating Scale .URMC, which is the University of Rochester Medical Center .edu. And on that website, we have several different resources. So we have the actual tests that we used, both Forms A and Forms B of the multiple choice, as well as the standardized videos, along with kind of the keys to scoring. So we've given kind of what we would score each of these as well, kind of the key to that. And we also have a variety of other educational modules, again, that we've not really covered here today, but illustrating various presentations of hypokinetic, parakinetic, and hyperkinetic catatonia for educational purposes.
Thank you. And I'd like to ask Dr. Wilson, you make it sound simple to assess catatonia in these critically ill patients. And I'm wondering what sort of a training effort that you do for the members of the research team who are doing those assessments. And do you have any information on these sorts of items that Dr. Wortzel and I were talking about of inter-rater agreement?
Our inter-rater agreement is quite high. So I've trained now a number of different trainees, residents, CL fellows, and more recently a research coordinator. So someone with a bachelor's degree who's now going back to graduate school to do these assessments. And as you highlight, it can be quite challenging, even for our advanced psychiatric trainees. So there's a lot of training that takes place just in my office, one-on-one, talking through unique scenarios. Then we go to the bedside for our patients, for our research patients, and we examine them together. There's oftentimes a number of teaching points that I'm highlighting there that can only be highlighted at the bedside. And then once I'm fairly confident that they've gotten the hang of how to do a catatonia assessment in someone who's comatose, then we go through a number of different essentially trials where they go in, they score the patient. I go in immediately thereafter. We don't discuss the patient at all. I score the patient, and then we calculate agreement, and we keep doing that until our agreement is high.
That's very helpful. And perhaps someday you can also find the time and resources to create a training methodology that could be shared.
Absolutely.
I think that would help the field considerably. Do you have anything to say about treatment where catatonia and delirium coexist as of yet?
I don't have anything unique to say about that. I think you highlight a unique challenge in one, just convincing funders to fund this type of research, because we've done a really good job about talking about the dangers of benzodiazepines instead of hypnotics in the critically ill patient population that I study. And in fact, my own research group years ago published a fairly convincing figure that showed that with increasing doses of lorazepam, you actually convert everyone into delirium eventually. So we've recognized really well that benzodiazepines, in particular lorazepam and others, are risk factors for converting into delirium. And so we have to weigh the risk and benefits of using a benzodiazepine in a patient who is catatonic or catatonic and delirious. And I usually have to consider how severe is the catatonia, right? If this is something that continues on, are they at risk for some of those morbidities that I talked about on the first slide? If they are, if the risk is high enough, I talk with the family, I talk with the treating team, and we consider a low dose Ativan trial.
Is there any consistency of a sequence, that is to say, delirium precedes catatonia, catatonia precedes delirium?
I don't think that's been evaluated yet. That's an excellent question. It's difficult to study in a true sense, because even though we have a longitudinal cohort study, by the time that we're enrolling patients, when they hit the ICU floor, most of them are already delirious.
Okay.
And many of them are also experiencing significant signs of catatonia. So really, in order to elicit that, as some other studies have shown, you would almost have to evaluate the patient in the preclinical context in their home, because many of them are becoming delirious at home.
We'll see if others have questions.
Yeah, so I wanted to make a quick comment about kind of the resources that we've made available and just the kind of the idea of standardizing the Bush-Francis. So this is something that Dr. Francis, again, we really genuinely appreciate your collaboration on this project. This has been a long time in coming. This was all like pre-COVID, actually, when all this began. So this has taken quite a bit of time to percolate.
For many hours of grilling.
Oh, wow. Yeah, no, exactly. But I wanted to dive into that because I think there's some interesting nuggets here. So, you know, when we were putting this together, kind of defining and kind of really operationalizing it, first off, I want to say how little I feel like I knew at the time, now having come this far and putting it together. You know, Josh and I did not know the answers. We are not experts in the sense of, you know, we have the golden ticket. We know the answers. But, you know, I guess I'm curious here. You know, when you look at these results, this is a question to Dr. Francis, actually. You know, when you look at these results and you see the tremendous heterogeneity of scoring across the spectrum of students, residents, and psychiatrists, now you travel all around to talk about catatonia. I'm curious how this resonates with your experience at different institutions, because I have to imagine that without clear videographic, you know, definitions of these findings, because they're very experiential in a way, clinically experienced. If this resonates with your kind of what you've noticed at different institutions and what you make of the broad heterogeneity in scoring.
Well, I would answer in two ways. One is the videos are very important. So several times at the psychosomatics conference, I have given video presentations, video teach-ins, using my extensive collection of real patient videos before, during, and after treatment. And when I travel to give talks and lectures at medical centers, I always manage to find a way to spend time with the trainees showing those videos. I think that's a very important modality. And I'm glad that you've included the standardized patient videos in this new training and educational system that you developed at Rochester. So I'm older, I'm a New Yorker, I'm more tolerant perhaps than you are.
Well, I'm curious, but again, just to the heterogeneity piece. I mean, is this something that you typically encounter, that people, you know, when you're teaching each of these items and you're going through item by item, if you're finding that people define them differently, if they think about them differently, if they have different mental conceptions, because, you know, how we think about these and our mental conceptions play a huge role in whether we're even going to notice it. And a lot of people think about catatonia as that's schizophrenia, right? Well, I mean,
Right.
Sure, in some sense, but kind of thinking about epidemiologically, that's only a small fraction of the patients. And so I guess I'm just curious if the heterogeneity is something you would have expected, predicted, or if it's something that in some sense is more surprising based on your experiences.
Well, I mean, I would frame the heterogeneity differently and welcome it. And that is broadening the phenotype of catatonia. So that's part of the heterogeneity of thinking about and applying it to other populations, as Dr. Wilson is doing to the severely mentally ill, and others are doing with respect to developmentally disordered patients, autistic patients, et cetera. So I'm on the one hand, that aspect of heterogeneity of catatonia is a plus. The detailed diagnostic details, the detailed diagnostic elements of it, I think are less important. I think people are thinking about it and looking to find it in these subpopulations, broadening the phenotype, a bigger tent for catatonia. So I'm all in favor of that. And yes, of course, I would like more rigor in how it's recognized and quantified and assessed. But I don't want to scare people away from thinking about and doing.
Oh, I don't want to steer people out. No, I want to bring people in. I want a massive tent, everyone under the tent right now. And I guess one final question that I have, and this is kind of for everyone here, right? So you know, we've defined these criteria in the items in the Bush-Francis a very specific way. Now, it's not to say that these are empirically the right way. I mean, that we're defining them wrong. I mean, we should define them the same. I mean, at the very base of the pyramid, you have to have reliability. I mean, nothing's going to build on top of this unless we are reliable and consistent across raters and across time, even using the scale ourselves. But I'm curious now, kind of what are the next steps, and just kind of what are the next steps in refining our understanding of the phenotype and understanding how best to define these items? Like, what is the next step in catatonia research that ideally this kind of work, this kind of education might help bolster? Where are we going next?
Well, Josh, you're doing it.
Well, thank you. I mean, I guess I would almost answer the question with another question, which I guess is a very psychiatric thing to do. But you know, there are all these different scales and they're defining features differently in some cases. And so is perhaps one thing we need to do, hopefully coming to a consensus about what each of these features is. So maybe a next step would be working with the DSM to say, hey, do we really need to define waxy flexibility differently? Because it's contributing to there being misconceptions of what one thing is. That would be, I think, perhaps one step that we could take.
Well, I mean, when we designed the scale, we were very explicit to the extent we could be about operationally defining exactly what each item was. And you're amplifying that with the project. And I think Jill will ultimately produce a methodology paper of adaptations of catatonia assessment in the critically ill population.
I think we need to do that. Andy, I think that's a really good point. I think what we also have to do is ask ourselves whether or not we know what catatonia truly is. Okay, we're talking about catatonia as though we know what the gold standard assessment and diagnosis of catatonia should be. I think we need to also be humble and recognize that these are the best reference standards that we have available right now.
Right.
And you know, some of our earlier work from 2015 and earlier looked at the diagnostic criteria and structure of catatonia, and we found that, you know, nearly 70% of the variance of the disorder is not explained by the common factors that we typically load Bush-Francis items onto: increased, decreased, and abnormal psychomotor behavior. So I think as our research kind of evolves into understanding mechanisms, people like Sebastian Walter and others out of Switzerland and Germany are doing great neuroimaging studies in catatonia cohorts, that we have to also see whether or not there are unique pathways involved in particular manifestations and phenotypes of catatonia.
Mm-hmm. We also need information on the time course, because the time constancy of catatonia is really not well understood. Does it fluctuate like delirium? Where delirium and catatonia coexist, is there more fluctuation than, quote, without delirium? We don't really know the time course of delirium. Kalbaum said it can fluctuate, and he's writing in 1874. We have better methodologies to assess that, but it really hasn't been done. We do not. Is there diurnal variation in catatonia? Does it fluctuate from hour to hour? We don't really know that, and that's really an unmet need, and that would very much help progress in this domain, especially in terms of biological research.
And I think that would also tap into this idea that we were talking about just a moment ago in the keys to scoring, which is that, you know, differentiating an interval assessment versus a state assessment. Again, it's not clear when you look at the literature, the period over which catatonic symptoms are being included as potentially, you know, kind of loading onto this score. I suspect there's probably a great deal of heterogeneity. So when it's reported, I think refining that and reporting explicitly will be very helpful to ensure that we know exactly what people are seeing, what was done, and the like. I think that's really important.
Yes, I agree.
I'm curious, anybody else have questions? Dr. Wortzel, Dr. Wilson, any other questions from you guys? We're probably getting close to the end of the time anyway, but I'm just curious if there are additional questions here.
I guess I did have one question for Dr. Wilson regarding the use of different scales in the 2017 study. When you decide to use, for instance, the DSM versus the Bush-Francis, and the merits of using both, if you could just kind of shed light on that.
So we evaluate for catatonia at the bedside using the Bush-Francis Catatonia Rating Scale, and then we convert that using an algorithm to a DSM-5 score. So as you likely know, there's a unique distribution of catatonia items in the Bush-Francis that all account for all 12 DSM-5 items present. So we're able to generate a score. And I think in a larger, maybe perhaps more well-funded study in the future, we would have unique and independent raters doing DSM-5 or the next iteration of the DSM evaluation, as well as other rating scales like the Bush-Francis.
But I would point out that the DSM is actually not a rating scale. It's a diagnostic system.
That's correct. Yes. So that's why, for the purpose of that 2017 paper, we did the evaluation using the Bush-Francis, but had to make the diagnosis using DSM-5.
I see. Okay. Thank you.
Right. A silver standard, I might say.
Exactly. So I'm looking here. I think we're pretty much at the end of time here. So with that, I think we'll have to wrap up. We really appreciate everybody's participation here in hanging with us here to the very last of this workshop. And I really appreciate my colleagues here presenting on this. So again, have a great day. Thank you so much.
Thank you all.
Thank you.